मॉनिटर दिस साइड नहीं दिख रहा है मेरे को, यहाँ पे डाल दिए
टॉप ले टॉप
ये वाला मॉनिटर. No, turn this side. ये ऑफ कर लीजिए.
टॉप ले टॉप
वो निकाल दीजिए. आई डोंट वांट इट. गुड. राइट. हाँ ओके. डून सुपर. स्पाइन नीडल. थैंक यू. निकाल दीजिए. ಥ್ಯಾಂಕ್ ಯು. ನೀವು ಬಂದು ಸ್ವಲ್ಪ ಹೊತ್ತಾಯ್ತಾ? ನೀವು ಬಂದು ಸ್ವಲ್ಪ ಹೊತ್ತಾಯ್ತಾ? ಸೊ ದೇ ವರ್ ನಾಟ್ ಟೈಟ್ ಜಾಯಿಂಟ್. स्मॉल मस्किटो.
मस्किटो छोटा वाला है क्या? छोटा वाला
ओके गॉट. ಏಜ್ ಎಷ್ಟು?
60 years.
Right. Which got switch. No, I want this. I will not do anything about it. Okay, no? Really? Okay, switch. Internotation how much? Internotation how much? Right. Open and close. Adrenaline added in saline?
हाँ उसको ही खोलना है.
वो खोलने बोलो.
एड्रेनलिन वाला कर लो.
Right. Okay, छोड़ दीजिए.
सेक्शन
सलाइन में डाल दिया.
सेक्शन कम करो ना. हाँ कर रहे.
लवाज.
वो लवाज प्रेस करना. प्रेस लवाज. हाँ प्रेस करके पकड़. हाँ ओके.
राइट. डाल दिया एड्रेनल.
यस सर.
राइट. स्विच.
टोका
Nair. ಇಲ್ಲೊಂದು ಚಿಕನ್ ಲೈನ್ ಅದು ಹಾಕ್ತೀನಿ. Sure. Hand switch. Okay. ಇದು ಆ ಕಡೆ ಹಾಕೊಳ್ಳಿ. पटक से दे दो अभी. ट्रिपल लोडेड सिरेनिक स्टैंड बाय.
293.
पटक से करो. We can go online if possible. So, okay. काम नहीं कर रहा है.
पानी में मत देना बोला.
Hello.
Trivedi sir, Dr. Prakash Ayyadurai sir, Dr. Ranjit Panigrahi sir, and Dr. Debashish Mishra sir. Sir, please.
Hello.
Hi, Ayyappan, are you ready?
Hello, Mr. Jaina, 60-year-old male.
Right. I can't hear anything from that side.
Dr. Ayyappan,
Yes.
Hello.
we can hear you, we can see you.
Can you hear me?
That's the
Can
case
you
first.
hear me?
Yeah.
Right.
Hello.
Can you increase the volume for Dr. Ayyappan?
Can you hear me? Right.
Yeah, Dr. Ayyappan. Yeah.
I can hear you well now. Arif, please.
Hello.
Sir, this is a, I think, 60-year-old male patient. Can you hear me, please?
Yes.
Yeah, 60-year-old male patient. So came with a history of trauma on clinical examination, forward flexion 90, abduction 90, active and passive. So, and basically when we look at the scans, if somebody can show the scans, so the scan shows that there is a rotator cuff tear. It's like a grade 1 retraction of the cuff. But the shoulder is extremely clinically very tight. So what I've done is I've done a global release inside. So I'll try to show it was very tight for the joint to go in. This camera was not going in, so it was very tight. We've done a good release, and so now the joint is quite spacious inside. Interarticularly space is good. So now I've come subacromial. We can see the tear here. So I've done an acromioplasty already. So I'm just going for the this I've done acromioplasty.
So which you're using the posterior portal?
I'm still in the posterior portal. I have not switched the portal yet. I'm working through the lateral portal, transdeltoid portal. Increase the RF, please.
Apart from capsular tightness,
Sir.
any other injuries to report?
Yes, sir. Okay, there is apparently in the MRI there seems to be some tear in the labrum, but when I looked at it, I didn't find a significant labral tear. Rather, I did a complete capsular release for this patient. So, and that was the other injury which was there. Remaining was okay, sir. Subscap was okay. Only the supra was torn. Remaining was looking okay, sir. You can see the tear here. The tear was not.
Is the patient diabetic?
Is the patient diabetic? no it seems. Shaver, please.
Just trying to figure out why this shoulder became so stiff.
Maybe
That is-
maybe
that
post injury, sir. It was maybe some immobilization. Possibly could have been the reason, sir.
is- Right, maybe.
Yeah. So my clearance is fine. So I've done a. So just little more clearance here, just for my. So visualization. So just take little part of this bursa which is sitting down, and then we can go into the repair quickly. Right. Port switch, spine needle. So now, sir,
In such debate is,
sir.
in presence of capsulitis, should you repair the cuff or should you first deal with the capsulitis, let the shoulder recover and then operate?
Sir, so I looked at, I thought about it long back. So what I realized is, I did a few cases, okay, where I give a steroid shot, try to get the preoperative range and then do it. This patient didn't do well. So now my practice is that I do a release and do the capsular release, do a cuff repair, because over a period of time, cuff repair, the cuff might become more retracted. And then do a very aggressive physiotherapy. That means start rehabbing them from day one passive. And so my results are good with that. So my own experience taught me that, doing a prehab for a period of time, extended period of time, patient not improving well. So I've changed my practice accordingly. Spine needle.
Would you have considered hydro distension and mobilization
Sir,
at least for 4 to 6 weeks before? Because this cuff tear looks very small.
Sir, I wouldn't do, sir, because again from my experience, that I didn't find in my patients, I didn't find a prehab or an injection. Then hydrodilatation, I don't believe it works because I feel the evidence is biased. And we have seen, sir, when we operate on the cuffs, we have seen how a cuff is and also seen how the capsule and the labrum is. I really don't understand how much of an amount of fluid you push into a joint, it can get distended and the capsule will release. It will not happen. The capsule is so tight and thick.
It works in hydro distension.
I don't
Maybe
believe in that
also
concept
some
at
fluid.
all. Yes, sir. Yes, sir. That. Okay, bar please. Anchor, triple loaded anchor comes in. Anchor. Sleeve please.
Right.
Spine needle.
I'll stand with Ayyappan on this one. Dr. Ayyappan, you have.
Oh yes, my good
Yeah.
friend Prakash. Yes. So yeah, out. So I'm just artery. I'm changing just the port for my anchor insertion. There we go. And yeah, I'm using a triple loaded tape anchor. Out. Yeah, in please. Go.
The small cuffs causes big pain,
Yes.
and so I'm just thinking if we don't operate on this one and then let them be conservatively for the stiffness, only pain be the cause for stiffness.
I believe that the pain, okay, so because of the pain and the capsular reaction is synovitis is the reason for the pain and then stiffness. If you actually, in the beginning of the surgery, the rotator interval is so tight and scarred up. It's very tight and scarred up. The MGHL was extremely thickened. So,
Ayyappan, I would be inclined to treat this as a post-traumatic adhesive capsulitis
Yes.
rather than cuff tear, because this much supraspinatus tear won't give any weakness so to perceive by the patient at this age.
maybe, sir, but I think the tear must also could have happened because of the trauma, is what I'm thinking.
I agree that it is post-traumatic,
Yes, sir.
But-
Yes, sir. It is correct. It is post-traumatic tear with stiffness.
which is very small, but stiffness is much more. Say 90% problem is patient's pain and stiffness rather than weakness.
One risk you
Canla.
run, if you treat this as capsulitis, inject steroids, there is a risk that the patient may not come on the OT table.
So I did that, sir.
That's the risk
Then
of
you
reconsideration to another surgeon. Sir.
Charge more for this patient for injection, equivalent to your surgery,
Out. Hold.
and offer free
Switch it
surgery.
Right. So I'm using a triple load tape anchors. So what I've done, I put the, if you notice, okay, I put the anchor quite a bit towards the cartilage. Now I'm taking the sutures, going in and spanning it, planning for a double row.
So would you do two double loaded here or a single triple loaded?
A single triple loaded with a lateral row. Yeah.
Two lateral row but single medial row.
Yes.
That we
No,
are
no,
getting.
no. I think it is one is more than enough, sir. Okay, we will see. I
Okay.
always keep it open if I feel that do I need a two lateral row and all that. So scorpion once and then that. We will. I always keep it open if I see that just one is enough. Okay, that's fine. If I'm getting a good coverage, so double loading. Ilva. Yeah. Just loading up the suture passer. So hold away. Right. Cannula withdraw, please. AC on, please. It's getting hot. I've done a. Okay. Switch it to yours. Yeah. Pass that car. Load this again. Load with the yeah. With ceramics one. Yeah. Show please. Okay. Hold away. So I'm using two different companies of suture passes, trying out each. No. So take it off. Pull it out. Pull it out. It didn't look. Hold scope. Right. Do scorpion. Where is other one? Unload. Right. Switch it over, please. Water change, please. Water change, please. One of the switches didn't pass well. Water change and AC. Load. Correct. Huh? No, correct. Pass. Scorpion. So. We'll try that one. Load. Right. Hold away.
Ayyappan, talk us through, please, what you are
Yeah,
thinking.
so I was just, this is a double loaded scorpion which I was trying to do. So yeah, you can see I passed both the switches together, and then that saves me a lot of steps. So I don't have to do the repeat passage. You can see that I passed both together. So here, so I am taking this, pull this also.
Dr. Ayyappan,
Yes, bye.
yes, so where exactly do you take the bites?
Yeah, so I'll tell you. So here, 1 second. Yeah, so if you can see, one, you should try to span it, number one. See here, you can see one has gone deeper, one is here. I wouldn't take same, all in the same direction, same in the same spot, because again, chance for tendon rupture is much more. So I would kind of one up, one here, one up, one here, then span it across.
How
Then-
close to the musculotendinous junction do you want to go?
No, the problem is, see, especially what we find is, this much is the footprint.
Yeah.
This, and if I pass it here,
Yeah.
here, the tendon comes and sits only here. Unless and until I pass all the way in, this will not come and sit over here. That means only then the lateral row work. So I pass at least 1.5 centimeter in. Right. Where is that? Can we put some adrenaline in the? So some bleeding is there. So I would flush, please, and then I prefer putting some adrenaline in 1 in 1 lakh adrenaline in the saline, especially it's a reactive shoulder. If this is a reactive shoulder, you can see that it is initially it was holding on because I had already put 1 ampule of adrenaline in this 3 liter of saline. It really helps because the bleeding kind of quickly comes down.
So only in one of your salines, or every saline will have this combo?
No, only one. Okay, when I want more bleeding control. Otherwise, I don't do it. Sure. Then, yeah, load up, please. The other one. The other one.
Why can't we do a single row on this patient?
You can, but I see again when I look at the biomechanics and the healing, which is better, always a double row is better. So, if you want complete footprint coverage, you don't want any gapping in between. So definitely, I would the double row is always better. Biomechanically, which is stronger, double row is better. So.
And since you have released, you want to mobilize this very quickly.
Yes.
And the pro will help you with the mobilization also.
Right, sir. So you want a quick, fast, aggressive mobilization. So I'd start my passive mobilization. Passive mobilization quickly. Switch it over. So here, okay, I'll just try to see. Pull that switches early. If my reduction is fine, do I need any additional switches now, etc.? I would check now. So this is what I'm planning. So whizzing it out, please.
You're going to tie the middle knots or just?
I will because for me sometimes I don't tie up. If the bone quality is good, I don't tie up. If it is osteoporotic, definitely I would. If it is a more retracted, I would. So here I would maybe add one more cinch. So fiber wire, please. I don't need an extra anchor here, so I'll just take a cinch suture with a single fiber wire. I would incorporate that in the repair, this spot. You can see that it is not, there is some gapping there. I might get away with it, but I would like to have one little more binding over there. So I would do that. Okay. So, right. So that is, I'm waiting for my fiber wire to come in to give me one extra bite over there, and then I do a microfracture. Hold candle. Right, this corner. Watch. Yeah. So I want a small bite. I don't want too deep a bite. Here, cinch, please. All microfracture all. Right. All.
So what is your view on this new patches, sir?
Okay, go. So me or Sanjay sir?
No, Dr. Sanjay.
Yes. Sir. Okay, go.
I am not.
Go.
You haven't used a patch yet.
Go.
I have used, but I'm not convinced that it's going to be any game changer.
Okay. What were your indications for the
Right.
patch?
Go.
No, if I feel that there are a lot of degenerative changes in the cuff.
Go.
I did one last week where the cuff was looking horrible. I could repair it, but the cuff was, tear was
Go.
essentially degenerative. Then you may want to put a patch, but I'm really skeptical.
Go.
I think it won't stand the test of time,
Go.
and it's hugely expensive.
Go.
Yeah. Usually.
So we have to be conscious that our country, what they sell.
Right. Switch it over. Artery on this, please. So just now, even I believe I don't use patches very regularly, but I would definitely use a patch if the tissue quality is bad. That is my indication. I don't use it for a coverage, not for sure.
Ayyappan, when you don't tie the medial knots, are you worried about the pasta type of, lift off from spinatus?
No, sir. Sir, if it
is so deep.
Sir, if we didn't put a medial row anchor, yes, it will lift off. So here the anchor is medial row. Only one stitch okay is a problem like that. So if the anchor is medial row, definitely pull this. Anchor is medial row, anchor is pulled. Definitely it will not lift off, sir.
Right. If you tie the knots, it will not.
Yes.
But if you don't tie the medial knots,
Even then it will not, sir. Even it will not. That's what I believe, because if the anchor is medial, it will sit from that point. Here.
because when you pass a suture, at whatever level in the cuff tissue will be pulled toward your medial anchor, and that is where it will be fixed, and the rest of the leaf, redundant leaf, will cover the footprint. That is what I understand.
I have different thoughts on it, sir. One
Okay.
second. One second. Yeah. So this one, right? Not pusher. So I wouldn't tie at all. Without tying, it is actually good. The only thing is, yeah, put an artery, please. Come on. Right. Hold other threads away. You do pull it. Right.
There's nothing wrong in
Yeah, in tying actually, what the advantage of tying is that, okay, so the load is being taken up by the two sets of sutures, the medial as well as lateral. Otherwise, you are entirely dependent upon the lateral. Here, 60 years, okay, and all that, so we don't know about the tissue quality. But otherwise, when we look at intra-articular view, even after a repair is done, I don't find there is a difference as such, sir. Maybe theory-wise it is there, but I didn't find any difference when I look at the repair construct from intra-articular as well when we are tying or not tying.
Okay. Because when the tape is with the suture, I essentially believe that tape is for not tying the knot, and the suture you tie a knot. So it is a mix of both, and you achieve both the goals.
Right. So, Vishnu Rao, please.
There are more number of robos sold in India than in United States.
Yeah. That answers the question.
There is a little
Running
thread
this
is there.
time,
RF.
There are 2 or 3 studies which show that the biomechanical construct is much stronger if you tie the knot medially.
Yes.
I always tie it.
Yeah.
There is a trade-off between the strangulating the blood supply versus the stability. So triple loaded anchor, you pick and choose your battles.
Sir,
But tying is important in my mind.
yeah, tying actually,
Triple loaded, you can leave alone one each pair. Where I tie knot at the anchor, so that I convert them into non-sliding, so I can easily take them to any lateral anchors.
yes, sir. Sir, if you hear, okay, so I have not tied everything. I just tied 2 strands. Two of my
Yes,
threads
I
are
observed
two
that.
of my
That's
threads
why-
are free. So that gives me an adequate balance of things. Vishnu Rao.
Yeah. The tying with tapes is slightly fidgety, but it works.
Sir, if you look at the tape, I didn't tighten too much. See, just 2 sutures,
I can
just
see
2
that.
threads, because my idea was not to cause too much of constriction as such.
Yes.
So if you look at the blood supply between not much, it is still kind of okay.
Yes.
Right, hold please. Right, let's go.
Only arthroscopists thinks too much about these. Otherwise, trauma guys will put nails and everything
okay.
to it.
It is ceramics. Ceramics. Okay, so suture to her.
Dr. Ayyappan, you forgot to microfracture it.
I did it, by you didn't see.
I didn't
Yeah,
see
he
I
did
missed it.
multiple, yes.
I was quite I'm quite a little fanatic about it, so I did it.
Yeah.
You are Snyder fan?
No, sir, I'm my own fan. Sorry.
No, but it was described by Snyder in great detail, and Gattelman was the one who really propagated it further.
Sorry. Yeah, so go in the middle one. Posterior will put one more extra later. Okay, Akul.
I always use a single lateral row anchor. My point is just to push that tissue back into place. So
Here, because again, depending on one anchor, see, I don't know about the bone quality. Bone quality is not that great, so it is kind of little okay. So in that case, I don't want to entirely depend upon one anchor here. So that is the idea of
because you're tying it medially.
right.
I don't
But,
think the plays a role in biomechanics. Later.
so I am
Just to push the head down,
bone is actually
increase the contact area. Yeah.
the bone is actually a little soft, so I don't want to completely depend upon one anchor on the lateral side. So that's why I decided to put one more later.
Dr. Ajay Desai is with me. he uses one lateral row.
I would have definitely done here, but I've checked. Okay, so the bone quality is bad. That's why I took. This is one my backup sutures. Get open one, so I lock. Take the one of the threads from there. So I lock open karo. So I lock open karo.
How about balloon spaces, sir? Dr. Sanjay, sir? Balloon spaces.
Follow. उसका ये दे दे.
Again, not a great fan if you want somebody who is
Orange to the code.
wants a temporary relief for a year or
ये
two.
डाल कर help करो इनको.
Use it. But it is not
Put
a
it inside.
definitive. And therefore the window of cases
जल्दी
is,
सब डालो साथ में.
Tremendous pain relief in balloons.
yes,
Yes.
for some time.
Yes. For some time.
Next.
Now our patient, if he's going to spend few
Chakra,
lakhs
really.
Yeah.
and it will put
Next
for
one
some
more.
time, he is not going to pay. And then again you still have to do after that the same expensive reverse.
Yeah.
Pass.
What about you?
I haven't put balloons so far, but I find it a good idea. But you offer it to the patient if they accept this situation, that temporary,
This way.
say 6 months, 1 year relief,
It will
and
go.
they are happy about it. I don't mind at all.
So can you just
Pull the threads.
think about placing a balloon on top of this repair? If this was not a stiff patient, placing a balloon on this repair, won't that give that patient a little bit of a rehabilitative heads up? You have good
Pull
compression
the threads.
You
Hold
mean
this.
above the repair.
over and above the repair.
Mallet did.
Why?
Why would I add an expense on that?
Threads.
What
Because
is-
we know it is temporary. We know it's going to push the head down.
but why I want the head to be pushed down? This cuff,
Next.
if I have repaired it,
Next.
Yeah.
it's
Next.
not going to
Over.
hit the axon and re-tear.
Sure.
severely.
ಚೆನ್ನಾಗಿದೆ.
I don't see the
Hold.
need. Yes,
Mallet.
it's a partial repair.
Yeah.
Very bad, massive cuff
Correct,
tear.
correct,
I've
yeah.
just managed to pull some fiber supra, a
Yes.
little bit of supra,
Yeah.
and then
It makes sense. Yes. So what are your thoughts, Dr. Ayyappan, on this?
Sorry. Balloon.
Balloons.
Balloon. Okay, I definitely use a balloon. Sometimes it's an adjuvant when the tissue quality is not that great, and the repair is extremely osteoporotic, or it's like a yeah. So then definitely I would do it. I do balloon as standby. I definitely do it. When tissue quality is great and I want to protect a repair, I can do it at times. But as a standalone, okay, see, the balloon has specific indications. The balloon says that in kind of pseudoparalysis with at least 90 degrees of movement, with further movements of another 20 degrees with a steroid injection, with a local injection is a minimum required thing. And the anterior posterior force couple should be intact. Only then the balloon works. So as a standalone balloon, I don't use it. Because
Okay.
leave.
I think you're almost done.
Yeah, just last one more angle to go. Cut. Go. No, back up, no? So you want that? No, it is the other one. You could put that Sherlock. No, take it through it. It has to go through it. So don't pull it out. Just cut. Knife दे दो. Knife दे दो. Take the others. Load. Solo का loader दे दे. Orange color loader दे दे. Right. Okay, done. Now put it inside. Super. Yeah, I'm just hold that straight. Right. Yeah, before this is my last anchor, suture retriever. I would like to thank everybody, the faculty and the delegates who are watching, the two important companies who have supported Arthrex and mainly Ceronics. All these are Ceronics anchors. Really thank them for that. Dr. Ranaji, Dr. Partho, and all the members and organizers of the Odisha program. Thank you so much.
Dr. Ayyappan? Dr. Ayyappan?
Go. You tell me.
Hello?
Tell me, bye.
Dr. Ayyappan, thank you so much for that wonderful demonstration.
Thank you, thank you, thank you.
Yeah.
Thank you.
So we'll go on for the next talk, keynote lecture by Dr. Sanjay Desai.